Carolina with about 12 days and a week up left before I come back to civilization. So welcome once again to another edition of Pharmacology. We are going to go ahead and get started. Let's see, we got about 30 people in the room, and I guess others will continue to trickle in. Amir, Agnes, Barbara, Christian, Evelyn, Fedora, Guiniel, Graciela, Hugh Tron, that's a new name. Tell me if I'm mispronouncing it. Hugh. James, John, Joshua, Katrina, Kelly. That's a new name. Lawrence, Lee. Lee, why does your name have a yellow sign with an exclamation point? I have no idea what that means. Well, let's see you raising your hand now. And hold on. Yeah, I see you using your electronic. You have no idea either? I don't either. Yeah, it has a yellow yield sign with a exclamation point on it. I have no idea what that means. Maybe it's I have no idea. So let's see. Where were we? We have King Kasova, James, John, Joshua, Katrina, Kelly, Lawrence, Lee, Lisa, Marie, Michael, Monique, Neil, Nicole, Otoniel, Paul, Trevor, Ubaldo, Vincent, Wanda, and Wilma. Welcome all. Let's get started. Okay, so we've been talking about drugs, some of the basics. We'll finish up some of the basics tonight and then move into actual drugs that have to do with what you guys are doing on the ground, on site there. So when last we left off, this was the last slide that we looked at. It was talking about drug effectiveness. So the idea here is we were talking about dose response curve. That is the relationship between when a dose becomes effective versus the magnitude of its effectiveness. Okay, so like the threshold of its effectiveness and then where that kind of plateaus out. And let me get my little pencil over here. I will be so happy to get back to civilization. Lee, weren't you an Army officer? Okay, let's see. Drugs have no more than one effect. So let's take a look at this chart down here, right? If we look on our y-axis here, that's the effect of the drug, whatever that is. It really doesn't matter. And then on our x-axis is the dose. The idea here is if we start from the 0 point, right, and we move towards increasing our dose, at some point the effectiveness starts to get more and more, okay? And the more of a dose we give, the higher the effectiveness. But at a certain point, you have a diminishing return, if you will, for the investment of dose that you're putting in there. Because there is a certain point where no matter how much more you put in of a dose, you're not going to get any more effectiveness out of it. Now, over here we see drugs vary in effectiveness. This is because there are different sites of action, that is to say, different receptors. One drug may be have an affinity for one specific receptor, and we would call that being selective. And another drug may have an affinity for several types of receptors, and we would call that a non-selective drug. And which of those it is will determine how effective it is with a certain dose. You also have a word that we're going to throw around called affinity. Affinity is the strength of attraction that a drug has for a certain receptor. When we use the word affinity, guys, think more about electrochemical attractions. How strong I'm going to use these two words. This is only for instructional purposes, not necessarily the way it comes out. How strongly a positive and a negative attraction is to each other. If I've got two positives and one negative, okay, versus, for instance, let's say on the left-hand side, I've got two things that are positive, two items, two entities, two molecules, whatever you want to call it. So I've got two of those. And then on the left side, let's say I have one negative. I think you would agree that I have a buildup of the two positives are going to pull in that one negative very strongly, right? It's kind of two against one, if you will. That would be a much stronger affinity than if I had, say, two positives on the left and three negatives on the right. Okay? So affinity, loosely understood, would be the strength of attraction for the ligand. That's what we're going to call the thing that's going to bind to the receptor, or the ligand binding the receptor. And the last thing, the effectiveness of a drug is considered relative to its safety therapeutic index. We're going to get into that in about 2 slides here. I'll explain it more. And that's where we stopped the last time. That was the last slide we looked at. Okay, so if we take a peek here, again, drug dose on our x-axis. Now we're looking at percent of subjects, okay? When we talk about the concept of ED50, effective dose 50, what we're saying is, as I move to the right and give more and more of the dose, then I start to have an effect on more and more of the subjects, okay? At the point where 50% of those subjects have experienced the effect of the drug, that is my ED50. These are numbers that the FDA uses when they try to decide if a drug is safe, how many more trials does it need to go through, do we need to discontinue the trials, these kinds of decisions, okay? So ED50 is that number at which 50% of the subjects experience the effects of the dose. Okay, now let's go to therapeutic index, okay? Let's just go ahead and put them all up here. Okay. Now, we just defined, get my little pen, we've just defined ED50, okay? Dose at which 50% show a response. So you can probably pretty much extrapolate or intuit what LD, the lethal dose, is. It's that dose at which 50% of the population dies. Now, therapeutic index is going to be the ratio of those two. It's just going to be your LD50 over ED50. This is what tells you, it gives you two of the thresholds. It tells you that bottom threshold, I'm going to use the word bottom, it tells you the lowest threshold of the drug where 50% of the patients are going to experience a benefit from that dose. And then at the top of that threshold, it tells you where too much, where you're going to hit toxicity and it's no longer going to be safe. Okay, I use the words bottom and top for threshold. Okay, it would be more correctly described down here on this graph. Same thing, let's get ourselves oriented. On the x-axis, we have the dose. On the y-axis, we have the effect. Now, look here at the ED50. Based on this ED50, see the little sigmoidal curve we have going here? Okay, this happens to be for morphine. Okay, so for morphine, we start down here, and then with just giving just a little, you can see how high the effect goes. But then at some point, doesn't matter what you do, you're not going to get any more effect out of the drug. Now, where this ED50 is the, right in here, sorry, messy drawing, well, that's where half the population is going to show response. Okay, right? 0 is starting here, and we're moving this way. So the population half the population starts to show response at this turquoise colored sigmoidal line. That means that everything in here that I'm coloring red now, everything in here is pretty much the margin of safety. But once you get past that purple line on the right, now you have hit the lethal dose 50, and when you start going past that, that's the dose at which 50% of the population died. So, said most simply, the therapeutic index is the margin between the ED50 and the LD50. Okay, said in narrative, the therapeutic index exists between when 50% of the population has an effect and 50% of the population dies. All righty? Okay. So let's talk about the word potency now. So potency, relative strength for a given dose. Okay? We're talking about the strength of the response for a given dose. Now, I put the entire narrative here. The effective concentration is the concentration of an agonist needed to elicit half the maximum biological response. Now, since we already know what the EC50 is, and we talked about, I say know what it is, we talked about the ED50, the EC50 is pretty much the same thing if you substitute the word concentration for the word effect. Okay, so EC50 is the concentration that you need of that drug to get half of the maximum response. Now, you know what, I should go back because I shouldn't make it that simple. It's going to sound oversimplified. I want to show you something here. On this one, when we did ED50, the half is the population, okay? ED50 is the dose at which half of the population shows a response, but they did not measure the response. They didn't say half a response or a full response. That part was left open. So effective dose, 50% of the population. Versus when we're talking about potency, the half, let me get my little pencil back here, the half refers to the response. Okay, so you want to keep those straight in your mind between ED50 and EC50. Now, given that we know EC50, we go from figuring out our EC50 to potency. The potency of an agonist is inversely related to its EC50. So if you know EC50, potency is just 1 over EC50. Okay? So we've got three concepts of math to deal with this LD50, half the population dies, ED50, half the population has an effective dose, EC50 is when half of the response is felt by the population, and then you put a 1 over that and you've got the potency. Now, remember when we were doing the respirations, right? I said that to me respirations, that chapter was all about math, and that it would behoove us to become experts not only in knowing what the narrative sounds like, but how that narrative would be expressed in a mathematical equation, and how that mathematical equation will be portrayed in a graph. This is one of those. Pharmacokinetics and pharmacodynamics, pharmacology in general, lends itself to expressions on graphs. So let's get really comfortable, guys, with knowing what left shift and right shift imply when we look at drugs. All right? Let's take a look here. So remember, the topic is dose response curves. Okay? Now the idea here is, let's just take the definition and first just memorize it for what it is, and then as we move through other screens, you get a more understanding of why it is that way. We talked about the word potency, okay? Potency increases as your curve goes to the left. Potency increases as your curve goes to the left. Okay, trying to think of, I always talk about how if you memorize one thing, you never memorize just that one thing. Try to use other things that you've learned to package it into like the same shelf in your brain. If you remember the oxygen dissociation curve, right? At least this is the way I remember it, so it comes out in the same way, with the same words. For oxygen dissociation, as my curve moves to the left, my oxygen stays on my hemoglobin because it has a stronger affinity for it. As my curve moves to the right, my oxygen is released. It dissociates from my hemoglobin because it has a weaker bonding. If you remember the oxygen dissociation curve that way, then you can also just plug this in with the same concept, that with dosages of a drug, as your curve shifts to the left, there's a greater potency. As your curve shifts to the right, there's a lesser potency. Now, shifting the curve to the left could be because of a greater affinity. Just like I said, oxygen has a greater affinity to the hemoglobin. It could be for other reasons too, but I'm trying to give you the catch-all that makes it easy to remember so you don't have to start learning curves all over again. Excuse me. So that said, let's look down here at the bottom and we'll see two drugs. One which is more left shifted than the other. So without even looking at the graph, if I tell you that fluoxetine is more left shifted in its potency curve than amitriptyline, you should automatically know that fluoxetine has a greater potency. But let's prove it to ourselves, right? Let's look down here. We've got dose on the x-axis and effectiveness on the y-axis. So if I tell you, let's start at this one. Let's say that this dose is about 8 milligrams, this blue dot that I'm drawing around here. So this is telling us that when we go from, I don't know, call it 7 actually. When we go from about 7 milligrams to 8 milligrams in a dose, we move from about 10% effectiveness all the way up to 40% effectiveness. But to do that for amitriptyline, we need to be way down here on this dose axis, closer to what? I don't know, 80? We need to be at 80 and pump it all the way up to 90 before we get the same 40% effectiveness. Okay, so we've just proven to ourselves that the drug which is left shifted the most is the one that is most potent. Okay, let me take a break. I'm going to look over here, see if I've got any questions. Let's see. Question about the safe zone. Let me back up. There we go. So shouldn't the safe zone then be LD50 to ED50? You are correct. You probably put that on there because you were just high speed, no drag, and you probably put that on before I actually got to that slide. Good job, Amir. Donnie, keep doing what you're doing. Let's see, what else do we have? Please repeat what you said about potency. Okay. I see, Donnie, you must be in your zone. Whatever it was, it must be very potent. Okay. So just repeating what I said about potency. To get to potency, we have to start from effective concentration. Effective concentration is that concentration where half of the biological response has been achieved. Now, you get yourself into trouble if you try to figure out what that half is. That's one of those that, my brain tried to run. What do you mean? Half of a headache is gone? I don't know what that means. Half of my indigestion is gone. Half of my depression is relieved. Okay. I would encourage you to just accept that whoever measured half, that they did their entire PhD thesis on that, and our job is not to understand it. Our job is to accept the measurement that concentration is where half of their whatever it was relieved. Okay? After you know that number, just put a 1 over it. Okay? And then you have potency. That number is the effective concentration, where half of whatever their illness was relieved, and then you just stick a 1 over it, and now you have potency. Okay? So to get to potency, you have to go through EC50. All right. Now a different concept from potency is efficacy. So let's think about this thing called efficacy. And these two things are really easy to get confused in the mind, guys. All right, so efficacy is the maximum possible effect, now here's the important part, relative to other agents, okay? Relative to other agents. This is why it really tells you nothing when a drug manufacturer making drug A runs a commercial against a placebo, and then a drug manufacturer making drug B runs their commercial against a placebo. Why don't they go head to head? That is where we can get true efficacy and say whether or not A is better than B in its potency. Okay? So efficacy is the maximum possible effect relative to other agents, even if that agent is no drug at all. Now, It is indicated by the peak of the drug response curve. So look over here. Okay, so we're talking there versus there. Okay, some of medicine is science, and some of it's language. What we're about to enter is the language part here. We have drugs that are called full agonists. So let's define agonist first. An agonist is a drug that activates, that potentiates, these are two words that you'll see, the receptor. They make it happen. They turn it on. Well, and the implication here is 100 with 100% efficacy. A partial agonist, we saw that a couple of times when we did the endocrine section, when it came to, when did we have partial agonists? Oh, fertility drugs. Because, yeah, we were dealing with partial agonists there. Maybe I'll go back and grab one of those examples. Later on, we're doing GI stuff now, so we'll leave it there. Partial agonist implies that there's only 50% efficacy. Antagonist, remember, is a drug that will bind the receptor in such a way that it cannot do what it's supposed to do. Well, that makes sense that you have 0% efficacy because it's not doing what it's supposed to do. Okay, and then here's the one that's really kind of freaky. Inverse agonist, which is 100% efficacy. So the idea with inverse agonists is there is more than one mechanism of action through which it can work. For instance, it may turn on a different receptor that triggers a physiological response similar to the first receptor. What's an example? H2 blocker is an example. We'll go into more detail by the end of this lesson. H2 blocker is an example of something that is more a inverse agonist than anything else. Okay, but let's look over here to the side. And we have the drugs morphine that we're talking about. Okay, we've got dose on the x-axis. We've got pain relief on the y-axis. The idea is that we're comparing morphine to ibuprofen and aspirin. Okay, so based off of this graph, what we can say by looking at it is, also keep in mind, the more left shifted the curve, the more efficient or efficacy it has. So with morphine, it is the most left shifted of all. It has the most efficacy compared to ibuprofen. We have to get way out here at 100 units. Morphine was less than 1 unit. It was like a half of a unit. And ibuprofen was 100 units. And it looks like aspirin is about 500 units. Whatever those units are, we're able to compare the efficacy of morphine, ibuprofen, and aspirin. 500. I'm sorry, I'm just trying to figure out what those units are. I've been doing more training with those high-speed, low-drag special forces medics, and we did a mass casualty today. And the only thing everybody gave was 5 milligrams of morphine in 5 cc's of normal saline. So I'm looking at this 5, and I think I know what their units are. But yeah, we were actually, in real life, in fake mass casualties. The weird thing is we could not give aspirin Not that the soldier would have wanted it. Anyway, but because of its effect on the platelets, it turns out that aspirin is contraindicated in an active duty soldier because of the effect it has on the platelets. It irreversibly acetylates the platelets so that uh, they act as a blood thinner, right? The platelets are supposed to help form the fibrin clot in your blood. And if you have aspirin on board, you have thinned out blood. And for soldiers going to battle, that's a bad thing because most of the time you're going to be an urgent surgical evac back to wherever's going to fix you up. Therefore, if you get pain on the battlefield, you're more likely to get morphine than anything, even if your pain could have been taken care of with aspirin. How wild is that? Okay, so let me peek over here, see if we have any questions. I assumed you were kidding, my friend. Okay, definition of potency you provided. Definition of potency. So potency is 1 over the EC, the effective concentration. Definition of potency, 1 over EC. Okay. How about Dilaudid on this scale for comparison? I don't know. That's a good question. And I don't even know why they don't have it in our little medic pack that we were experimenting with today. But it'd be nice to see what you come up with if you Google, for instance, Dilaudid versus morphine. That would be interesting. Okay, I'm reading a question. Inverse agonist is 100% negative effect, right? Inverse agonist is 100% negative effect. Oh, I see what you're saying. Yes. Yes. Inverse agonist is 100% negative effect. You think it's micromoles per liter? I assume you're talking about the morphine. Micromoles per liter. Micromoles per liter. I don't know, but now my weakness with wanting to figure out useless facts is going to go in overdrive after this session is done. And that's going to be the first place I go. Micromoles per liter for the morphine. Thank you, Evelyn. Wonderful drug, morphine. Yep, you got it, Amir. That's why they give the morphine, because the aspirin would be an anticoagulant. Oh, we got a lot of people with morphine experience out there. And Wanda asks, what is an inverse agonist? An inverse agonist is the one that is the most difficult to understand, Wanda. So what I'm doing is I'm going to give 3 examples of inverse agonists, 1 tonight and 2 in the next lecture, because this is one of those. It's more easily explained when I go through the mechanism of action than just giving you a narrative definition. So yeah, the one you get on the slide is that the inverse agonist affects 100% of the negative original action. I know that sounds like it makes no sense. Yeah, I'm going to have to go with H2 blockers, and then when we talk about specific mechanisms, I think if we do it about 3 or 4 times, you'll be able to pick out the subtle difference between an inverse agonist and an antagonist. Because on any test, those are the 2 that they're going to try to make you tease between. You'll know what an agonist is. It activates it. You'll know what an antagonist is because it just blocks it but doesn't let it do anything. And then an inverse agonist, it's not going to, an inverse agonist doesn't just block it so that the receptor is not working at all. An inverse agonist sometimes with H2 blockers, for instance, an H2 blocker will block the histidine receptor so that histidine never gets a chance to activate acid and release acid, okay? As opposed to something that would just block, yeah, I can't say it that way. I'm going to finish this sentence, but it still might not be clear. If I gave you something that just simply blocked the hydrogen potassium ATPase, that is the gastric pump that pumps out hydrogen into the stomach, okay? Excuse me. And, hold on, you know what, let me see. Yeah, I can go into that now. I'm going to try to give you two examples of something that antagonizes and something that is a inverse agonist. So you have a patient. That patient comes to you and says, hey doc, I've got a problem. I feel a burning in my stomach. Sorry, let me see. Testing 1, 2, 3. Testing 1, 2, 3. Okay, I've got a full bar, Marie, so I'm sorry. And you seem to be the only one complaining right now. Going to have to refer you to your hardware. Let's see. Okay, so we've gone far enough. There's more that I'm going to show you in this session, but just so you don't go for the rest of the session wondering the difference between inverse agonist and antagonist, I think we've gone far enough for me to be able to use this example. Excuse me. Okay, so patient comes in and says, hey doc, I'm having pain, and it's so much pain in my stomach, epigastric pain actually. I'm having epigastric pain, though they wouldn't use that word. I'm having epigastric pain, and it's so bad that I've lost 10 pounds over the last month because I just don't want to eat. I'm so afraid of the pain. Okay, so then you ask them the question, does eating make the pain better or worse? If they say that eating makes the pain better, then you know that they have a problem going on in their duodenum, peptic ulcer disease located in the duodenum. If they say eating makes the pain worse, then the problem, the peptic ulcer disease, is in their stomach proper. Okay? We'll go deeper into this in our physiology class, but just as a once-over, the idea behind this is that it's acid, it's hydrogen protons that are causing the pain. So what happens when I eat food? What happens in my stomach? I get an increase of gastric acid that is secreted. So that's the patient, when they eat, the pain gets worse because they're having an overproduction of gastric acid in their stomach. Now, the person that eats and the pain gets better, you know it's in their duodenum, because what's the job of the lesion is in the duodenum, because what's the job of the duodenum? One of them is to raise the pH of that chyme that is leaving the stomach. It raises the pH up so that it can circulate through the rest of the GI tract, all right? So therefore, patient, Does eating make your pain better? Oh, it's better because the acid is being neutralized in your duodenum, and you have an insult in your duodenum. Or does it make it worse? Oh, of course. Every time you eat, you get more acid in your stomach. That's what's making it worse. So we've already localized it. Okay. Now, one of two of the drugs you can give for that. One of them is an antagonist, and one of them is going to be an inverse agonist. The antagonist is the one that you give that will block the hydrogen potassium ATPase. This is an enzyme whose job it's in the parietal cell, and its job is to pump out hydrogens into the stomach after you have eaten food. If we use a drug that blocks that pump, and when we say block, what I mean is this ligand, the drug, binds with that pump in an irreversible way so that the pump is permanently broken. Now, make no mistake, the body's going to make more of them because that's just what it does. But we have a drug that has bound directly to that pump so that hydrogen protons cannot be pumped out into the stomach. That is an antagonist versus an H2. The name of it is unfortunate. Okay? H2 blocker. An H2 blocker, despite its name blocker, it's not a true antagonist because the job of the H2 blocker, as it's named, is that drug binds histamine receptors because it is the job of histamine to activate the acid secretion. So it's one level removed from the actual pump. They call that inverse agonist. It's one of those things you have to go, that's what they say it is, and by definition it is. And you can spend a lot of time on trying to understand it, which I do encourage. I'm going to give more examples so that you'll be able to find the common thread between them. But I think with just these two examples, contrasting a true antagonist with an inverse agonist, you can see one of the subtle differences, at least between these two drugs. One is working directly at the site, and it's basically breaking the system. It's just a wrench that's thrown into the machinery, and it's not going to let it work. Okay, and the other being an inverse agonist, which is going to block the site and keep it from doing something else downstream. Okay, so hopefully that helped with a partial understanding, and as I give the other examples, you'll be able to, as I said just now, find a thread that connects them all. Okay. And Lawrence, where will you find these? You'll find these on the Google Drive. My plan, I was trying to figure out a way to have fewer things on the Google Drive. And this is what I'm going to do. You remember before I said the way that you guys are going to get your final exam is I'll have a review, and then you'll be able to just go back to the PowerPoint of that review. Okay, so I'm going to still do that, but there's something else I'm going to do which I believe is going to be helpful. At the end of each month, well, let me start at the beginning. At the beginning of each month or each module, okay, we're going to have modules like this one's going to be, it's pharmacology, but it's going to focus on the topic of GI. So I'm going to try to make all of the lessons GI, which means that at the end of this module, what I want to be able to give you is a set of slides that is all pharmacology GI related. That means that if there are 4 sessions we have in the month, you're going to get one session that's, 20 slides long. The second session is going to be 40 slides, but it's just because I'm going to add the second 20 slides on there. The third session, I'm going to send you something that's 60 slides long. And the fourth session is just going to have all of it. So what I'm saying is by the fourth session, you really only need 2 slide sets by the end of each module. Just that fourth one, which is going to have the entire month's lessons on it, and the review, which you'll have right before the test. So I'm just trying to minimize the, the stuff that you guys have to look through. It'll be consolidated all together. So that said, there's 20 slides from the previous section, which I have not given to admin. I'm adding on the 22, 23 slides from tonight's section. So I'll leave it up to you whether or not you want to wait until the end of the module to get them all, or if you want to download them week by week. If you do, just realize there will be redundancy, only because I'm trying to make it efficient for you at the end. Alrighty. Let's see. So that is efficacy. Tolerance, also known as desensitization. Okay? So the idea with desensitization is, excuse me, you have a, this is one of those areas where you have to make sure that you're listening in the way that you hear things, because I may not say it in the way that you like to hear it. I don't mind restating it. There's just more than one way to say it. So, tolerance, desensitization, decreased response to the same dose. Okay? Decreased response to the same dose. Or, if you want to say it in the converse, it becomes more drug is needed to achieve the same effect. Whichever way your brain likes to hear, that's the way I encourage you to take it in. Either way, we still have to know that it is a rightward shift of the dose-response curve. Well, that makes sense, right? If I told you earlier that left shifting a dose-response curve was an increase in potency, then it kind of makes sense that a right shift of the dose-response curve is a decrease in potency, which is the same thing as saying you need more of the drug to achieve the same effect, which is the same thing as saying a decreased response. Okay? Can you see how those start to overlap? I say overlap because they're not exactly the same thing, and you do want to keep them separate in your head. Okay, and remember that you can develop tolerance by cross tolerance, or shall I say tolerance across different drug, not classes, across different drugs. Okay, drugs in the same class. Maybe you're given one drug and then given another, and you can develop a tolerance for the other, even though you've only taken the one. All right, and this is just an example of the graphing of what desensitization would look like. We still have the dose on the x-axis, and then we have the effect on the y-axis. And the idea here is that this was our original dose, where getting up to whatever this horizontal line is, whatever number that is, it looks like about half. It looks like about half of the effect. When the person first started taking that drug, it only took 1.5 units, right here, 1.5 units of that drug to get halfway up the scale for effect. And then as time went on, it took, what, 2, 3, 4 of those units to still make it up to that same half of the effect, okay? So be able to recognize a right-shifted drug response curve as a graphic representation of tolerance, or desensitization is the other word for it. Okay, if we have desensitization, then of course we're going to talk about sensitization. Let me, excuse me, let me just check the time. All right, 9:30, so as usual, we're going to drive right through to 9:45, so we've got about 18 minutes left here. You can make it, you can make it. So sensitization, excuse me, kind of makes sense that if I told you desensitization was a rightward shift, that sensitization is a leftward shift. Sensitization and potency you can look at in the same neighborhood of definitions. It's not the same house, but it's kind of like the same street, the same neighborhood, going in the same direction, which is to say, it only takes a little bit of this stuff to obtain a very high degree of reaction. All right, let's look at some of the specifics here. Sensitization means an increased response to the same dose. Okay? Or you can call it less drug is needed to achieve the same effect. Or we can just say there's a leftward shift of the dose response curve, and sometimes, as an example, sometimes this occurs with an acute dose like amphetamine. So the idea is that you might take one dose of it, and then each time you take it, it has a stronger and stronger effect. Okay, so that's just going to be the opposite of what we talked about earlier. They're using cocaine as the drug itself. Excuse me. And cocaine's ability to induce seizures as the reaction. So the idea is that in the beginning, you have this dose way out here, 1, 2, 3, 4 units, okay? You have 4 units of cocaine that's able to get you up to the number 50 right here for seizure induction. And then as time passes, you only need 3 units of cocaine to get you to that same 50 units, for lack of a better word, for the effect. That is sensitization. All right. Now, drug-drug interactions. All right. So, remembering back to pharmacokinetics and pharmacodynamics. The way I remember dynamics, this one down here, pharmacodynamics is what the drug does to the body, okay? Which the alliteration of the D's. The dynamic is what the drug does to the body, okay? Pharmacokinetics is what the body does to the drug. Okay? Pharmacodynamics is what the drug does to the body. Pharmacokinetics, the other one's the other one. Now, when we're talking about drug interactions, we're talking about how one drug may add to the effectiveness of another, may subtract from it, may cancel it out. We're going to talk about 4 or 5 different reactions or interactions. Cumulative, I'm down here on the bottom, additive, synergistic, and antagonistic. All right, so let's just look at those. Okay, I can tell you, you can expect to see these graphs on your midterm. Just because there's so many graphs on the boards, and we might as well be comfortable with it. Okay, let me just take a pause. Let me look over here. Oh, that's pretty good. Vincent has given us a little ditty to memorize, potency and, well, I guess it's potency. Less is left. I like that. Less is left. Left shifted curves, the dose response curve, when it's left shifted, that's less. Less potent. Great. Thanks, Vincent. If you are right, you are insensitive to more drugs. Okay, those who like that, use that. I like your less is left and the other one's the other one. Okay. Drugs are dynamic, bodies are kinetic. Very nice. You're figuring out your stuff as you write it down. Okay. Whenever I'm right, my wife says I'm insensitive. Okay. All right, let me see. Let's just go back. I want to make sure all of those match. Whenever I'm right, hold on. Whenever I'm right, my wife says I'm insensitive. So you're saying insensitive is desensitization, I guess. Let's see. Whenever I'm right, and we're saying it is, whenever I'm right, my wife says I'm insensitive. Yep, that works. Rightward shift of the DR curve. And then less is left. Let's just check that. Less is left. Well, I guess the problem, less what is left, Vincent? Which one were you talking about? Was it efficacy? Can't remember now, I'm sorry. It was, okay, so potency, with potency, the left shift has greater potency. Okay, so it's not potency. With efficacy, no. With tolerance, you must be talking about less drug needed. Okay, this must be the one you're talking about, Vincent. So you're talking about the word sensitization. So you're saying less is left. Less, and this is a wonderful lesson in memorizing or in making up your own acronyms and your anagrams. When you use an adjective in your ditty to memorize, the assumption is you really have to remember which noun you're talking about, or when you use any modifier. So with less is left, it's less drug is the point. Less drug is needed, and that's a leftward shift in the dose response curve, which is the way Vincent is memorizing sensitization. Okay? All right, guys, thanks for those. Let's see, so let me go back. And Janelle says, I thought left is more. Yep, that's the point right there. So you are correct, Janelle, depending on which concept you're thinking about. Vincent's thinking about amount of the drug because you're sensitized. It's not right or wrong. You just have to remember what you remember. Alrighty. So let's talk about cumulative effects. With cumulative effects, with this, I got this chart off the internet, and I haven't quite made up my mind, but I think this ought to say drug A rather than drug B. Because when we talk about cumulative effects, at least with how this definition goes, it says the condition in which repeated administration of a drug may produce effects that are more pronounced than those produced by the first dose. So what they're saying holds true whether or not we're talking about, let's just start out with this idea of talking about a drug. When I give this drug, let's look on our x-axis, we have time. On our y-axis, we have response. If I give this drug, the longer I give this drug on that first dose, then I come back with a second dose. Whether it's a different drug or the same drug, they're saying that the response now goes up like this. That is cumulative. And that means if I give it again, I'm just going to make this up, then I should have a response that looks like this. Okay? The point is, every time you give the drug, the next administration of the drug, or a different drug, which is in the same class but similar to it, will have a cumulative effect. And it's like getting a head start on the dose, if you will, okay? All right, so that's cumulative. Be able to recognize that for your exam. Additive. Cumulative and additive are definitely the two that you'll be asked to tease apart. Now the idea here is the effect of two chemicals is equal to the sum of the effect of the two chemicals if they were taken separately. Okay, so keep in mind that again we have to measure response, whatever that means. Okay, so if I say to you that, I don't know, let's say this is a headache, and the doctor says, yeah, a migraine. And the doctor says, on a scale of 1 to 10, how does your migraine feel? And you say, the patient says, doc, it feels like a 10. But when I take this drug, A, it goes down by 3 points. Or there's another drug, it's just as good, doc. When I take it, it goes down by 4 points. But when I take both of those drugs together, it goes down by 7 points. Okay, that's additive. That is not the same as cumulative. Cumulative is saying, doc, you know what? When I take drug A, then it went down. Let me get my pencil. We'll use the same number. 3 points. When I took drug A on Monday, it went down by 3 points. But when I took drug A on Tuesday, wow, it went down by 4 points. And then when I took it on Wednesday, it went down by 6 points. Okay, that's cumulative. That is not the same thing as additive. All right. Now let's look at synergistic. With synergistic, sorry, let me just peek at the clock. 4 minutes. Alrighty. With synergistic, we have the effect of two chemicals taken together is greater than the sum of their separate effect at the same doses. Okay, this is what they mean when they talk about taking certain, I don't know, sleep agents with alcohol, sedatives with alcohol. That's saying, okay, doc, let me think. Yeah, I'm going to have to make up, well, not make up a word. If I have a hard problem sleeping, okay, a hard time sleeping, and I have insomnia, I'm going to define that as wakefulness. I have to just because it works out this way. That is my wakefulness, okay? So when I take a sleeping drug, let's say sleeping drug A decreases my wakefulness by 3 units, okay? Brings it down. Drug B, that decreases my wakefulness by 3 units. You know, 2 different drugs. I can't really tell the difference, but I kind of fall asleep about the same time, no matter which one I take. But when I take them together, then all of a sudden it decreases my wakefulness by 9, and I just can't stay awake. Okay? So it's not that it was 3 plus 3, right? That would have been additive. It's that A plus B is greater than what A and B were separately. Okay, all you got to do is just, we're gonna go over some drugs that have all of these different effects during the next lecture, so you can actually see it in real world. And let me just go over here, see if I've got any questions. Yes, I'm here. We're going to get all kinds of examples on the next lecture. Yes, synergistic is like the celebrities found dead in their hotel rooms after overdosing on prescription drugs and alcohol. Yes, yes, because they're probably thinking, oh, it's a little alcohol, it's a little drugs. I know what's going on. Maybe they're assuming it would have an additive effect, and it has actually a synergistic effect. Good example, Red Bull and vodka. I don't know, but somebody's going to have to tell me. All right. And the very last one for the night, antagonistic effect. You kind of can guess that one, right? That's basically I take 2 drugs together, but somehow the second thing that I took affects the first thing and makes both of them less. Grapefruit juice and, thinking CYP450 enzyme in the liver. And the idea is if I take one substance with another, then it reduces the efficacy of that first substance. All right? Okay, guys, so there we go. You have done it one more time. Wasted 90 perfectly good minutes of your life with me. I hope it was worth it. I'm having fun in this pharmacology. So we are halfway through the GI section, which means you should be saying to yourself, what, we're halfway through and you haven't even given us any drugs yet. I know, it's because you're going to get hit with them really hard over the next 2 sessions. Okay, so The next examples of the drugs, we're going to talk mostly about describing them in the language that we just identified tonight, and we should get a lot of good drugs in. All right, guys, for those of you enrolled in physiology, anatomy, and or the board review, I will see you a couple more times this week. For the rest, I will see you in about 6 days. So have a wonderful night, a better tomorrow, and a great weekend. Bye-bye.